Hello, welcome to HLA Live. HLA Live is our regular broadcast on the HLA YouTube channel as well as all the other social media channels. Each week we talk to interesting people from across the HLA community.
Good evening, everyone. I am really excited to be chairing tonight's meeting.
Hi, I'm Rosie Spooner and I'm hosting HLA Live this Wednesday.
And I'm an HLA scholar and I'm also going to be your host this evening.
To share with us their ideas and their innovations and hopefully bring them to a global audience.
Quite quick, we have ideas, let's do this, let's do that. So
many of the topics come from our community, with scholars and faculty expressing an interest in many of the discussions that we're about to have.
Hello everyone and welcome to the HLA Live session on widening participation in the postgraduate realm.
Homelessness and health.
Addiction and the new normal.
HLA programs are built on 6 pillars. The leader is an innovator and entrepreneur. The leader is a communicator. The leader is a manager. The leader as a negotiator. The leader as a follower. And the leader as a philosopher. If you are interested in becoming a HLA scholar, why not get in contact? Many of the episodes in HLA Live will cover one or more of these important pillars. The HLA team consists of Pedra, Eamon, Tim, Riddy, Alistair, Adil and Trisha, and a range of other HLA scholars and faculty.
James is the founder of Somex, which is a communications company. He also writes for Forbes and he's the host and producer of the Health Tech podcast. So be a really interesting speaker to hear from. And over to you, James. Thank you very much for joining us.
Hey everybody, and thanks for inviting me to speak to you. My name's James. I am a doctor by background in anaesthetics and intensive care, and I've done a fair amount of stuff in innovation and technology, call it. And so I've been asked today to talk a bit about my journey, which I'll do. I'll touch on how I innovated as a clinician, or at least tried to, and learned a lot by doing that. And how I then, I suppose, took that learning into policy and then broader into more commercial healthcare. I've now got a company of my own doing innovation and communication for health tech companies, and that's called Somex. But I will talk you through that entire journey. I also speak to quite a lot of innovators and entrepreneurs on my podcast, the Health Tech Podcast, and I write about them for Forbes as a contributor as well. But I guess my journey starts when, well, let's start at medical school. So I was a pretty average medical student. They say that, what do they say, that 50% of doctors are below average, although 0% of them would admit it. I'm probably one of those that might have admitted it clinically. I never loved the medicine. I never found my home there. And actually, I just recorded a podcast with someone from GSK who was a doctor, and he used the phrase that he was a distracted medical student. And I would agree with that. And I really kind of empathize with that, excuse me, because I was exactly that. I was distracted by other things. And I think it was certainly distracted by enjoying myself and stuff at university and medical school. But even when I graduated, whilst I really enjoyed the job itself, because it was more about kind of getting things done and building relationships with different people in the team and the hospitals to actually, you know, get your radiology done before anyone else's, or get your patients fed, or get, you know, make sure the nurses with the drug charts get there first to yours, you know, all that sort of stuff I enjoyed. And it was about people and, as I say, getting things done. I did enjoy that side of the job. But what I never really, not grasped, but I suppose what I never really truly thoroughly enjoyed was the medicine behind that. I couldn't get myself excited about the intricacies of this drug over that drug and this study over that study. It never really did it for me, because I guess I wanted, I saw myself doing other things ultimately and leaning into other interests. And so the way that manifested itself was through quality improvement projects, which at the time for me weren't seen as tick box exercises. I mean, yes, I did tick those boxes, frankly, you know, those forms that you've got to tick, or the competencies you've got to tick to get full marks for your next application. Just get those done, will be my advice. Just do whatever you need to do, whatever quick audit or whatever you need to do, just get that done. And then you can actually focus, if you do have an interest in this stuff, on actually improving stuff and actually innovating. And so my innovation as a junior doctor started with fixing a printer, funnily enough. And it was a printer in the doctor's mess. There were, I think, 3 or 4 printers in there. Only one of them worked, and it was just a simple case of everyone getting frustrated in the mornings. The queue was going out the door of the doctor's mess just because everyone was printing one-sided on this one printer out of 4. And that meant ward rounds started late, which meant that ward rounds finished late, which means that some patients didn't get fed on time. Extreme cases, surgery was cancelled for some of these things. And yes, there's a Swiss cheese model there of other things getting involved, but it didn't take a lot of effort, ringing a few people, getting a few things done, calling in a few favors and all the rest of it, but got the printers fixed. And it was a really funny one because what I saw very early on, this was in the first few weeks of being an F1, I just saw how fixing something as innocuous as a couple of printers can have such a massive effect on so many people, both clinicians and patients. Because ultimately those ward rounds did start earlier. They went quicker. They were more streamlined. Stuff like we used less paper. They queue out the door, which meant that people weren't as stressed in the mornings and they could actually have a coffee and chat to each other. You never know what all the benefits that could have been made over something, as I say, as innocuous as that. But to cut a longer-ish story short, I then started to do other things. I noticed that in our hospital at the time, discharge summaries just weren't being done. They were days, weeks old. There were stacks of notes in the doctor's mess, literally up to the ceiling, multiple of these things for just like discharge summaries that hadn't been done. And that was because of a number of things. The computers were slow. They took 10 minutes to load up. It was a weird system that you had to load up to even write the discharge summaries. They required so much information that didn't matter. And so it was a case of like, what do we actually need to do here? And I was on MAU at the time. I was the F1, excuse me, on MAU. And I was doing the most amount of discharge summaries out of everyone in the hospital. So what I did was I was like, who actually reads this? What actually happens to this? And it's the GP that it matters to. So rang a couple of GPs and was just like, what do you actually need from this? Because we're over here spending like 40 minutes per discharge summary. It's killing us. And they were like, look, just a white space box with just like what they came in with, what you did and what you want us to do. That's it. And so I put together, I suppose, a focus group, if you want to call it that, of like a couple of GPs from the community, a couple of the medical consultants, a couple of the senior registrars, because the senior registrars are the people that actually get things done in a hospital because they have credibility all the way up and all the way down, and amongst people, that is. So put together a few of those people, a couple of people from IT, this, that, and the other. Anyway, an hour and 20 minutes later, we then arrived at, we just need to put a white space answer for people to just type that quick stuff. And all of a sudden, you just saw the discharge summaries go down to the floor, and all of a sudden, everyone was getting the discharge summary within 24 hours of being gone from hospital. And I wasn't the only person part of that project, but it was again one of those things where it's like, it doesn't have to be that complicated. You can just start from the end and work back. What are we looking to achieve here? Let's work backwards. So I suppose as a doctor, the then kind of, I suppose, big project that I did was that when I was on neonates, so premature babies, there was a ward round that I used to do on special care, which was the babies that had been kept in for suspected sepsis. So whether that's meconium or whatever it is at birth, like whatever's going to give them suspected sepsis, they get blood cultures taken as soon as they're born. 48 hours later, they go home. Now, in the day, if you were born in the day, you went home after 48 hours. If you were born at night, it was 72 hours, 84 hours, 97 hours. It was a huge amount of time overnight. And by following a blood culture to realize what on earth happens and why is this happening, I realized that nobody was in the department to put to actually culture the blood overnight. And so what was happening overnight, they were stacking up. So whoever got their blood taken first overnight was right at the bottom of the pile. And then they'd only get, sorted, the afternoon later, the evening later. It was one of those things where it was like light bulb moment. Hey, there's something to be fixed there. So I wrote a business case. And to do that, I shadowed someone in finance to learn how to do it. And again, if I'm going to give any advice to the medical students in this audience, take some study leave, shadow some people in management. You're going to hear loads of stuff about them and us when you're a clinician, about managers. Like, oh, they just see you as a number, they go home at 5. Well, yeah, both those things are true because that's the job they picked. So if you want to go home at 5, go be a manager. Like it's not rocket science, but you'll still end up dragged into this kind of them and us as managers, but they are the same. They just probably made a better career choice if that's what you wanted. But the point is they're all very nice people. And so I shadowed people in finance and learned this thing called a business case. And hey, people really stand up and take notice of you when you've costed things properly, because money talks. And so in this example, I wrote a business case with someone called Linda in the finance department. She helped me. And we both then said, let's lease a new blood culture analyzer, stick it on the neonates ward, put the discharge dependent bloods through it. We'll get patients discharged within 48 hours, as we've said. Hunky dory will save the hospital 200 grand in year 1, 300 grand in year 2, blah, blah. And what I learned doing that project was super interesting, because whilst that was perfect on paper, it didn't end up happening for a couple of different reasons, all about how money moves in the hospital and why you actually shouldn't discharge people too quickly if you've got a really empty department, because then the hospital gets less money through the door because of how they're incentivized. But look, without getting into all that stuff, the point is I learned a heck of a lot doing stuff as a doctor, which gave me the grounding and I suppose the knowledge base of like, this is what I want to do. I want to be part of this stuff. Now, because I was doing all those projects, I was speaking to quite a lot of technology companies, because it was those people that I saw that could go in and change stuff, because I was using my iPhone to do everything else in my life, just never in the hospital. And things have changed a lot now. Bear in mind, I was at medical school, 10 years ago? So longer, in fact. I was a junior doctor 10 years ago. But anyway, so I then took a couple of years out of medicine and I did fellowships. Now, and by the way, I trained as an anaesthetist in that time. And I also did a degree in education because I loved teaching. But yeah, I took a couple of years out and spent time in policy. So I went to Health Education England, I went to NHS England. So these are the arm's length bodies to the Department of Health. And I learned the policy behind stuff, because when you're trying to make change at scale, when you're trying to innovate at scale within healthcare, often policy comes up as a barrier. And so what that allowed me to do was understand the back end of healthcare, understand how those big organizations all fit together, like NICE, the CQC, the BMJ, like NHS England, NHSX, NHS Digital, like all of that stuff. I understood during that couple of years, like how all that stuff fits together. Did some work for Tony Young, did some work, like all those different people that I was around, which was like really cool, like learn a load of stuff. Knew ultimately the policy wasn't for me, because all I was thinking was like, every time I'd learn something new in policy, it was like, oh, this is how I can now translate this to a tech company. I think I can tell a tech company this, and then a tech company can get into a hospital and then they can do stuff for patients. So that's the way I used to think. But anyway, after spending a couple of years in policy, I then moved to something called an accelerator, which was the perfect role for me. So an accelerator is a program that helps startups. So they help generally technology startups. They can be in anything, but there are loads of accelerators for technology startups. So startups will apply to an accelerator, and that accelerator will give them knowledge, support, advice, guidance, sometimes funding, so like cash to do stuff. But I joined one called the Digital Health London Accelerator, which was an NHS-based accelerator. It was just starting, so as part of kind of the initial team there, which was great. And I was something called a navigator, which is basically like an account manager for startups. So I looked after 10 startups and I was helping them get into the NHS, so market access for the NHS. And that was essentially just using everything I knew about how they should pitch to a clinical director, about how they should write their business case, what they should probably charge because of tendering or procurement rules, all the things that I'd learned along that journey, you know, shadowing in finance again, coming in very useful here. So yeah, I was a navigator for 6 months. I then got promoted to run the program with someone called Hannah, and the two of us ran that program then for another year. So I saw 61 startups go through that program. We got 50 pilots and contracts in the NHS with the companies that came through, 348 new sites in London with a new innovation, thanks to that accelerator. And we had companies on there, the likes of, you might have heard of Babylon, they've been through that accelerator. You might have heard of Medopad, or Humour as they're now called. They just raised 150 million odd, doing some cool stuff. We got the first contract with them at Chelsea and Westminster, which is quite cool. Echo, the pharmacy company that got acquired by McKesson and Lloyd's Pharmacy, they've been through that accelerator. So some really great names have been through there, and really great for me to connect with those people and to build that network myself, which was awesome. I then stepped into entrepreneurship, I suppose you'd call it. I met a guy called Alex, and the two of us had the idea for a different type of accelerator, an earlier stage accelerator that got all of this information into the minds of entrepreneurs that were just starting their companies in health tech. And so we started an accelerator called HS, which became HS Ventures. We partnered with charities to help charities invest money into the emerging technology in their space. So we partnered with the likes of Orthopedic Research UK, and they invested in some new orthopedic technology and things like that. So that was super exciting. Did that for a couple of years. And at the same time as that, I started writing for Forbes on health tech, as I mentioned at the start, just because I suppose my position in the space and I enjoyed writing. And again, another bit of advice: keep your hobbies, always keep going with your hobbies. You never know when you can monetize them and bring them into what you do. Started writing for Forbes, also started the podcast at that time, so the Health Tech Podcast. And again, that was just because I enjoy talking to people. I'm no good at small talk, I hate it, but I like going deep into a conversation with people, so podcasting was perfect for me. And with this network of healthcare technology, and the ability to speak all those different languages, you know, the tech, the clinical, the management, it was easy for me to kind of speak to all those different people about those different things and bring those worlds together on the podcast. And so that was 200 episodes ago, which is awesome. And I've spoken to some incredible people on that podcast, which is great. And I suppose the latest thing that I've now done is, because of Forbes, the podcast, and everything that we're doing in communication, realizing that so much of what I have done with accelerators and the support that I've given to startups and companies has been largely communication. What I've done now is set up a company called Somex with my co-founder Jessica, who's from a global PR agency in healthcare, big pharma, big medical device clients, and the two of us have set up an innovation and communications agency for health tech companies. And so what we do, two main things: we do press and PR for those companies, and that's Jess's background. We also do multimedia content, and this is where it leans into all of the hobbies that I've kept my entire life. So we do video, we do podcasts, we do graphic design, we do social media, and we take the keys of social media and we put all that stuff together, white label a podcast for clients, we video it, put the clips everywhere, blah, blah, blah. So we're basically this all-encompassing, innovative, very modern 2021 style communications agency, and our clients are seed to roughly Series B at the moment, health tech companies. We do actually have a multinational as well that we do stuff with, but yeah, that's essentially where it all kind of comes to a head, and that is essentially my journey.
Thank you very much, James. It's great to hear about some of what your journey's been, but also see some of your perspectives, because actually the that whole, you know, being a slightly, you didn't use the term dubious, but like being a slightly unsure junior doctor, being not the perfect sort of ideal of a junior doctor, and then wanting to kind of find somewhere to channel that energy, and you said quality improvement projects. I just thought that's such an interesting perspective, isn't it? Because we can get quite kind of wrapped up and frustrated with what's going on around us sometimes. So it's just get some thoughts on that, like focusing that energy on something actually productive that can lead somewhere else.
Yeah, I think I suppose the problem that I see now with quality improvement projects, or certainly when I speak to people, is that they've almost become commoditized now, and they've become a tick box. And I think that's a big problem, because ultimately what they were for me and a few others like me, who by the way are now like directors at Babylon and directors of big health tech companies, that was my cohort of people then. And because it wasn't, we didn't have to do it. And we had to do an audit, which is basically just read through a load of notes and fill out a form, and you just do whatever you could quickly to tick the box. But then we could do the stuff that we actually thought was valuable. I think that's the difference. I think whatever you can do to tick the boxes you need to do, and then just go with wherever medicine takes you. It's not the race to exam results anymore when you qualify and get on the wards. It's not a race to consultancy, because careful what you wish for. When you get there, you might have wished you'd taken a bit of time and seen your family a bit more, or not done that PhD, or, you know, there's lots of ways that you can make medicine work for you. And I didn't have any major role models in medicine that would speak honestly with me about this. I think it is slightly different now, because a lot more people, and I'm not the first person to leave medicine by any means, but I didn't know anyone that had. And so now I think most people will know someone that has, or at least they've got access to people that have, so they can hear a different perspective. Whereas everything I was told was like, you can't leave. Like, why? What are you going to do? It's like, well, anything. And like, we can't. But how? But what are you? And it was like, computer says no, and they're like, they couldn't actually fathom it. And they're not trying to give bad advice, but they're not qualified to advise me on how to leave medicine or whether to, because it's not an informed piece of advice. And I think, you know, when I speak to people, I think if you're going to stay in medicine, you've got to love it. But if you're going to leave medicine, you got to love that too. The grass isn't always greener. It's like, there's a lot of people that leave medicine for management consultancy, for example, and it's like if it's the lifestyle you're not enjoying, like, there's nothing to say that your life's going to be any better at Bain or McKinsey or anything like that. So, like, what's different here? Like, you know, so there's lots of different ways to approach that. But anyway, going back to your original point about quality improvement projects, yeah, it wasn't a tick box for us. So I think tick those boxes as quickly as you can, and allow yourself the freedom to find whatever it is within medicine that you do enjoy. And you don't have to excel academically, in research, in management, in teaching, in quality improvement, in innovation, in entrepreneurship. You don't have to excel in all of those things. You don't even need to excel in any of them, frankly. But with the freedom that the boxes are ticked and you're relaxed, you'll then gravitate to what I think you will enjoy best. And I think that's an important message.
Yeah. And I think that's a really interesting perspective. Personally, I came into medicine from a very different place. I'd done all sorts of things before I became a doctor, and came into it much later.
Sure.
And I found it very rigid. It was very difficult to go and do the things that I wanted to do, particularly as a foundation doctor. And that's just a frame shift of going into being a foundation doctor maybe 10 years after you, but actually some of those same issues are still around. So it's just super interesting to hear that kind of perspective. So then you've kind of challenged all of those sort of perceptions as a junior doctor, got involved with your quality improvement projects, and made some really great connections through it. How did you find it going then off and doing some kind of policy work and working with GPs and working with other people? Did you have any sort of resistance to doing that? Did you have any sort of challenges there to overcome, or were the trust actually totally cool with you doing it?
I mean, no. I mean, I had to. It was funny. It was the FMLM fellowship, the leadership fellowship. So it was called the Bruce Keogh one at the time when I did it. But no, they were not happy with me doing it. It was very strange. It was very bizarre. But I sort of doubled down and just said, cool, I'll quit. Like, that's fine. And I did, you know, and it didn't even occur to me that, like, why wouldn't I do this? It was such like, at the time, you look back and you're like, that really opened all the doors to what I do now, because it gave me time. It gave me a 9 to 5. And it gave me perspective as well, because it gave me the realization that there is all this other stuff that goes on in healthcare as an industry. And on one side, yes, the policy and all the ALBs to DH and that stuff, but on the other hand, you know, all the players from commercial industry, like, that come in to support that and make a lot of it happen. And it just gave me so much time and so much perspective. I mean, so much time. You're still working a 9 to 5, but you're only working a 9 to 5. And actually, when you go from an A&E rotation to working 9 to 5, it's like night and day. Like, the amount of headspace you've got and thinking time, and you can just take like an hour in the morning to, like, walk, or a long shower, and just think of idea. Like, it's amazing. Like, genuinely, like, it really did open the doors for me, that, because it showed me a lot of potential that I could then move into.
Yeah. And I think that that's the value of kind of being firm in your convictions, that actually this is something you want to do, and this is something that you're going to make work, isn't it? Rather than necessarily.
Yeah, I mean, that is a privilege, though, I must say. Like, you know, it's I was at a point where I could take that risk. Yeah. So it is a privilege to and that's not afforded to everyone who wouldn't. Some people might look at that and go like, I actually couldn't do that in case X, Y, Z. Yeah. So it always bear that in mind, I would say. But healthcare is a very, very, very big world. And there was a really interesting moment before we finish, but like, there's a really interesting moment that the time at which I could no longer apply for anything, that I had fully left. And like, I had to take that fellowship. And then I was sort of, it was as if that ice had broken and then I was just on the piece floating. I thought that would be super scary. It was super liberating, because in that very minute, that happened, I no longer saw myself in the context of my class at medical school that I was competing with, the junior doctors around me that I did my F1, F2 with. I no longer saw myself in that pool of people anymore. I was just in the pool of like the entire world. And I was like, I've got 3 degrees. I've got like 5 years of medicine behind me. I've got this, I've got this, I've got this, I've got this. In the context of the world, like, the opportunity is immense. And I think, again, it's a perspective shift, because you can really get bogged down into thinking like, this is it, you know, I have to make it in this narrow field or else like I'm a total failure. But yeah, it's super interesting for perspective. Definitely fellowships are the future for that, if you want to fit in and fit out of medicine.
Cool, thank you very much. There was one last question, if that's right. In some of the discussions before the talk, we've been asked a little bit about kind of pitching and about how to, you've touched on business cases anyway, but if you want to kind of pitch an idea to somebody and you want to try and get some funding, if I was to say, do you have like 3 top tips for how you would pitch an idea, how you would perhaps go about funding?
I don't know if I've got 3, but I would say that if you're going to do that, you have to have researched the problem extensively. You have to know every single thing about that problem you are trying to solve. You don't have to have built the solution. You have to have probably done something to build the solution, whether that's a prototype, whether that's a bit of code, whether that's, you know, something along those lines. You should have gone some way to testing your assumptions that this is going to work. So there needs to be evidence of that. Have you spoken to customers? What have they said? Have you documented that information? Have you changed anything as a result? Have you built anything as a result? Have you, you know, all that kind of stuff. I think where people fall down is they just think, oh, I've got an idea. It's a taxi that you can call on your iPhone and I'm going to go and get some funding. And it's like, everyone in the world's got that idea. How are you practically going to work that out? How are you going to get all these people on board, and then what's the platform you're going to build that connects them? How are you going to monetize it? How are you going to collect it? You know, so you've got to have the thinking and stuff along those lines, rather than just thinking, I've spotted a problem and therefore I need to raise some money to build a solution. That isn't working in the current market whatsoever. And what I would say is that, for, you know, it's mainly medics in this audience, right? You don't know everything as a medic. I don't know everything as a medic. You don't know everything as a medic. You don't. You've got one way of seeing the world. There are medics that have done computer science before. There are medics that have done engineers before. They are infinitely ahead, because they can do a ward round and envisage what needs building, what needs coding, what needs sorting from that perspective. So if you don't have an engineer or a computer science or something like that background, number one, learn it. You don't have to do it at university, but learn something along those lines. So at least you know what you're asking of other people at the very least. But 2, like, go and find a co-founder that can do that stuff. Have a few beers and a few conversations and see where that takes you, because you're going to get a brand new perspective of the way to build something by doing that stuff. So putting all that stuff together, and you if you come to somebody, an angel investor that might, you know, that, and you say, I'm a doctor, but I've actually been speaking to this engineer. This is a problem I've spotted. This is they have built. Like, we've done this market research. Like, this is the person that might buy it. They're probably going to buy it for around this. Like, and here it is. Like, that's very different. So like, I've got this idea. Can I have £1 million?
Fantastic. Thank you very much. It's been wonderful to have you with us and to get a different perspective on innovation as well. So thank you very, very much for joining us.
You're welcome. Thanks for having me.
Thank you to everyone that made tonight's episode possible. Whenever our scholars are thinking about complex problems facing our health systems, we encourage them to think about how they make significant change in the world of healthcare. We are incredibly lucky to have some incredible scholars in the HLA. They use the HLA as a platform to take their ideas and bring them to fruition. If you are interested in the work of the HLA, why not join us at one of our future HLA events? Why not join one of our programs? Why not even become a HLA scholar? Thank you for joining us. My name is Johan Marlewaner, the Director of the HLA, and it's a good night from all of us.